Hey there, and welcome to Hope Unscripted, a podcast of Hope Cancer Resources.
Here, we're having real conversations about cancer, from prevention and education to support, resources, and the stories that remind us that we are not alone.
And we're your host. I'm Jamie Dietrich.
And I'm Brittany Harmon, and we're so glad you're here.
Now let's talk about hope, healing, and the journey.
Unscripted. Welcome back to the Hope Unscripted podcast, where we talk about cancer care in our community. I'm Brittany Harmon, and today I'm joined by Julie Maday, who's the radiology clinic manager for Highlands Oncology. Thank you so much for joining us today, Julie.
Thank you so much for having me. I'm excited for this opportunity to kind of debunk myths or misconceptions around radiation.
And no, I'm super pumped. So let's start something simple then. When people hear the word radiology, a lot of times they think X-rays, MRI, just basic. What in that nutshell does that really mean?
Yes. So radiology and radiation it's very confusing, very close, very similar.
Yeah.
Radiology is kind of the heart of cancer care. That's their X-rays, their CT scans, their MRIs, and that kind of paints the picture of how we're going to treat them.
Okay.
And then they come into radiation, where we're using radiation to treat the cancer. So they work together, but very different. So we get lots of phone calls of, I need to schedule my MRI, and it's not the case.
It is. Oh, okay. Because that's when I hear radiology, that is what I think of first. And I didn't realize how close they work together, but they're extremely separate at the same time.
Yes.
So that's good to know.
Yes.
Just that huge part of the cancer treatment process. So you get diagnosed. That's the first thing you see is from the radiology side.
Yes.
And then from there is when they kind of decide if they even have to do radiation, because some don't have to. That's right.
Yes. Correct. Okay. There's so many different journeys. They might just need chemotherapy. They might need surgery, radiation, and then they might need all of us, two of us. But yeah, there's very different routes they can go.
Okay. What are some of the biggest misconceptions or myths? Like, let's bust some of these myths and not scare people so much, because I know that a lot of time when they hear they need radiation, their mind instantly goes crazy.
Yes. First thing is they start Googling, which I'm guilty too. But they'll start Googling and they see, horrible skin reactions, or they've had a loved one 20 years ago that had radiation treatment and their skin was falling off. And we're very site specific. Where we're treating is where they're going to have their side effects or their symptoms. If we're treating the breast and you have a stomach ache, it's not from us.
Yeah.
So most of the time we can say that wasn't from us. We're the nice guys. But so that's one of the things is, they see these horrible side effects. And in just the 12 years I've done this, I remember when I first started, we would have to put patients on break for skin breakdown, for a week or so. And then now I can't even tell you the last time I've seen somebody put on break for like their skin breaking down. Like you just don't see that anymore because of the technology that's advanced
so far. And it continues to go farther.
Yes.
And be, like you said, more site specific, where they're not. Like I think of the radiation chambers and your whole body's in there, even if it's one little spot that you need to take care of. So that's really cool to know.
Yeah.
Are there any other myths or things like that you can think of?
Yeah. I was just talking to one of our therapists this morning about this and this, and we were just like laughing about some of them. Shouldn't laugh, but a lot of patients think that's going to be these crazy Star Wars effects and lasers and beams coming out of the machine. And it's actually really boring, really anticlimactic. They lay on the treatment machine, goes up and under what looks like a huge KitchenAid mixer. They don't hear anything, they don't feel anything. Yeah. They don't see anything. They can't see the radiation. The machine just turns and buzzes around them, and that's it.
Okay.
Yeah.
Is it kind of like a tight quarter thing? Like I think of the MRI machine almost, and how it's like you're in this little tube for so long and you have to hold perfectly still. Did they have to do that also?
They have to hold very still. Okay. After they consult with our doctors, they'll come for their planning CT. And our job that day is not, we're past the diagnostic part. So we're getting them in a tolerable position that they can tolerate and lay still for their treatment, which is approximately about 15 minutes. Some treatments are longer, but on average, it's 15 minutes. So we work really hard that they can lay on that table and lay still. But the machine is actually very open, and, it rotates around them. So there's a lot of times where they don't see anything at all. But it's not like the MRIs at all.
Okay, that's awesome, because I wondered how long it was too, because, no idea. I've never experienced that. I know my aunt has had some radiation done, and it's been very site specific for her. And so she's been very fortunate to not have horrible side effects.
Yes.
But, you do hear all the old school skin falling off and some crazy things like that. And it would be scary to somebody who doesn't know.
Yeah, absolutely.
Walk us through what patients can realistically expect if this is their first time. They've already gotten their scan and they know that they're going to have to have radiation. What should they expect coming in that first time?
So the very first treatment that they have with us after the consult, like I said, will be their planning day. That's the first step. Is a lot of patients think that they're coming for their first treatment. Like, I'm here, let's do this. And it's like, actually, we're just planning today. So we make, get them in that position. We do a quick CT scan. Then it goes off to our dosimetrist. Really fancy word, but they're like smartest people I know. They are the ones that work closely with the physician and come up with a very unique plan to treat the patient, tailored to just them by using our planning scan and fusing it with their diagnostic studies that they've had to treat exactly where we need to. But they essentially are telling the machine how to manipulate and turn to treat exactly where we need to while avoiding all these critical structures to minimize all these side effects. So it's really neat to see them construct this plan.
That is something that's so fascinating to me, because that wouldn't have been something that was there 12 years ago or 20 years ago.
Just big open box and you just blast it.
Walk in there and hope for the best. Oh, so, wow. That's incredible.
And a lot of patients are like, okay, so I'll start tomorrow. And that's another thing too, is because of all the behind the scenes and the detailed planning that goes on, a lot of times they have to wait a week or two to start their treatment. Because then after that, our physicists, they have to make sure that the radiation that's coming out of the machine and the plan that they came up with is actually coming out accurately and delivering what it needs to.
So after the first couple of treatments, do you do another scan to see if it's working at that point, or what does that look like?
We do not. So they'll come for their first day for their treatment, and we show them where we sit. We can see and hear them at all times. We can communicate with them. We'll set them up in the room. That very first day, there's two things that I want to put out there for people to know. But you position them. We step out. Every day we take x-rays. Positioning them in the room, we can get within millimeters, but we want to be exact. Yeah. So we take the x-rays. We can overlay those with the plan. But after we take those x-rays, there's a pause in the room, and all the patients are laying there, and they're like, did they forget about me? I'm in here, nothing's happening. But that's us reviewing those images. Sometimes we have to have the radiation oncologist come approve those films. And then the table moves, and that's us doing that outside the room, getting them exactly where we want to treat, where we just imaged and said, this is where we want to go. So they lay there silently, and then the table moves, and it's like, whoa. Ooh. Yeah. So those are the biggest things that we try to point out to the patients. And then afterwards, they're always like, that's it. We're like, yeah, that's all the fun you get with us today. See you tomorrow.
Okay.
But yeah, so after a couple treatments, we don't do any scans during their course with us. Okay. Because the radiation is actively working. It's a buildup effect. So we don't want to see what those results are halfway through. We want to see it, weeks after they finish treatment to see where we're at.
I got you, because it's just slowly works in your body after the fact. So how many treatments roughly do people get? Does it just vary per diagnosis, basically?
Yes. Yeah. So we can see a patient one time. A lot of times we'll do one large treatment for maybe pain relief or certain treatment to the brain, or we could see them up to 40 days. There's all different variations.
And every day for 40 days.
If you have, so there's some that are one treatment, 3, 5, some of those are every other day, but typically on average, our patients have to come Monday through Friday, 5 to 6 weeks.
Wow.
Yeah.
Okay. That's intense.
Yes. It's a full-time job.
You get to know a lot of these patients and have a really close connection with them when something like that. Is there a patient story that has just stuck with you over the years?
I have thought about this because I'm they all I should journal up, throughout my career, because I'm there's so many of them. But most recently, that really stuck with me was there was this patient who had mobility limitations, and we're how do we get him over to our treatment table? How do we transfer him? And usually we would just use a Hoyer lift, and this patient was adamant, like, that's not going to work for me. They're like, okay, but we really need you to try it. And so we convinced this patient to do it, and he does it. He's in tears. I'm in tears. I'm like, okay, we're never doing that again. We will find a different way.
Yeah.
And we did. We were able to find a way, and it was great. And but the solar eclipse happened.
Oh yeah.
And so our company let everyone stop and go out and see this. And so we're outside in lawn chairs and stuff, and that was this patient's treatment time. And it just came up and sat with us and watched the solar eclipse. So
that's so special too at the same time.
Yeah.
I love that. I can imagine getting close to some of these patients. I know it's not always easy because they may not have the outcome that they needed from radiation. Does that happen pretty frequently?
I feel like we are more successful than not.
Okay, good.
But, if we can give them pain release or, anything, help them breathe a little bit better, then that's rewarding in itself.
Yeah.
Yeah.
Yeah. I can see that. A lot of patients will feel anxious for even just the first scan. So do you guys see them for their initial scans as well, or is it just the radiation afterwards?
We just see them for their radiation, but we get a lot of emotions that first planning day because they're like, I have no idea what to expect. We're very unknown. A lot of people don't know what we do. So once they come there, that day, we get all the emotions. We get anger, we get, fear. But that's where we can really sit with them and tell them it's really not going to be that bad. Mm-hmm. If you want to step in and see what the machine looks like to help you kind of mentally prepare, we can do that. After that, and then after their first treatment, a lot of their anxiety goes away, but it's really hard to get ahead of it because they have no idea. It's just
if you were just told and it wasn't something you were expecting.
Yeah.
I can imagine that initial fear and anger. That's a major emotion I feel like a lot of people have. I know I don't have personal, but I have family that has, and learning it. I know when I was 16, my grandfather got diagnosed with esophageal cancer, and I was so mad at the world for him.
Yeah.
And he was acting like, it's okay, it's going to be fine. And I'm like, no, it's not.
Yeah.
And back then, too, the medicine was so different back then.
Mm-hmm.
Highlands was really new in the area at that time. And so he just, wrote it out the best he could. And I think of all the different things that now are available to patients. And I'm so grateful for that and grateful for Highlands. And Highlands is such a huge supporter of us, Hope in general, and trying to take care of all these patients together.
Yes. Yeah. We're so grateful for you guys. You guys see our patients at consult and you tell them what's all available to them. And transportation, we were talking about how they have to come every day, and that's so important and necessary. They need to come every day for their treatments, and sometimes transportation is a limitation.
Yeah,
either they don't have a vehicle, or they don't feel well enough to drive, or heck, maybe they're scared to drive in Northwest Arkansas traffic, because I know I am.
I don't blame us for that one. Yeah.
So just those little things, and then you guys stepping in and driving them. I think I just saw a statistic of 3 million miles driven.
Yes. So we're on the way to 4 right now. I think, I know by the beginning of 2027, minimally, Hope will have driven almost 4 million miles for patients back and forth to take them to these appointments and take them to their chemotherapy appointments and things like that. Because it is, if you can't get to your appointment, that will delay everything.
Yeah. I know. It's you get this diagnosis, and then it's you have to come every day for 6 weeks. And it's how the heck am I going to do that? And it's you guys really step up. And our patients talk so greatly about the driver. So, one patient's they'll have the boost in the glove compartment and it'll get warmed up for me. And I'm like, oh, so
just
sweet.
try to give them some energy after all that. Because I'm sure it's exhausting to even lay there for 15 minutes if you're in a very stiff position. That would wear me out. I know I could do it right now. So what does an average behind the scenes day look for a radiation therapist?
Chaos. No, I'm just kidding.
But a little bit.
But we don't let anybody see that. No, it's on an average day. We treat patients every 15 minutes, and it's just in and out. But we're working behind the scenes with the doctors, the dosimetrists, the physicists, the nurses, coordinating care for inpatients, of how we're going to get them over here, or their side effects. But on the front end, our biggest thing is to make that patient feel like they're the only ones there.
Yeah.
So
That's very important.
yeah, but there's, a lot of troubleshooting on the machines, and
Imagine.
when, sometimes we're engineers all of a sudden.
Technology, man.
Yes.
It's
I know.
important, but
That's what I always tell our patients, like if something goes down and they're like, why are you running behind? I'm like, well, sometimes we love technology, but sometimes we really hate it.
Sometimes technology hates us.
Yes.
So, yeah, for sure. So the dosimetrist, is that the correct word?
Mhm.
I've never even heard that term.
Yep.
So let's expand on that. Do patients meet that person? Do
No.
they know what that is? I've
They're
never
like
heard
those
that.
secret people behind the
Yes.
scenes. Yes. No, actually, a lot of ours are remote, but we have been blessed with such an amazing team of dosimetrists. Like, they're the best of the best. I don't know how our dosimetry supervisor snagged all these ones,
Yeah.
but yeah, so they don't typically meet the patients. Our dosimetry supervisor, he's very hands-on. He's in the clinic and he's always out there, and he used to be a therapist, and so he'll get down there and
He's very
treat with
aware.
stuff. So,
Yeah.
yes, so he likes to be involved, but no, there's really no reason for the patients to get to know the dosimetrist.
Okay.
But yeah,
But that's cool to know that you have like an extra sidekick you don't know about,
yeah,
and be aware that that person is the one locating that spot and getting you right where you need to be.
yeah,
That is so cool to me.
Yeah. Yeah.
And they're all remote and they can all do that. Even
Yes.
just seeing it, that's just amazing to me.
yeah. And there's some complex plans that they'll work days on, but it's just so neat that they can create something like computerized, and then for it to go out to our machines, and our machines are moving what way it told it to go, and
That is,
Yeah.
it's just so intense. So to be a dosimetrist, I'm assuming it's a lot like you probably go to medical, some type of school for something like that.
yes, yeah. There's different journeys that, pathways that they can go, but usually they'll do radiation therapy, and then they'll go on to dosimetry.
So they
school.
learn a lot about what it takes to be
Yeah.
a dosimetrist.
Yeah.
That is just such a cool term. It's going to stick in my head
Yeah,
now.
I know.
love
They're
that.
the specialist of dose.
Yes. I love that.
Yeah.
Just even all that, it just highlights how much coordination it takes to have this between your oncologist doctor, your radiation therapist, your dosimetrist, and then your other support systems. That just, people all care, and they
Yeah.
all want to take care of these patients. And that's just a blessing to
Yeah.
me.
That's what I'm like. It's so cool that all of us, it takes all of us to take care of one person.
That's it. It's like, they always say it takes a village to raise a child. Or it
Yeah.
takes a village to
Yes.
take care of a patient too.
Yeah.
And their family and all of that. So do you deal with whenever somebody comes in and their family's there,
Mhm.
does it ever get a little anxiety in there whenever a family member's in there? Is it better if it's just a patient by themselves? What does that look like?
Yeah, we actually can't have family members back there. Sometimes, we can bring them back there and show them the room and say, this is where they're being treated. But it does make it a lot harder when the families are in there. But sometimes they need it. Sometimes that helps relieve their anxiety. One time I taped a picture on top of our machine, this lady's husband. And so she would stare at and
Watch her
while she was being treated, and the machine would rotate, and she'd look over here at it, But yeah, it's really hard having them in the room because it's very quick. And a lot of times patients are in pain, and so we're trying to move quickly. And so then, we feel bad, like, okay, now we got to usher you out.
Yeah.
But yeah, a lot of times having them in the room can be harder.
Yeah. But again, 15 minutes on average, if they know that they're out there, at
Yeah.
least they can be in the building and some
Yeah,
things like
absolutely. Yeah, they can definitely, be in the waiting area with them, and we always reassure them, we'll bring them back to you in one piece, 15 minutes.
And that's what I think of too. So radiation therapists are emotional support too at the end of the day.
Mhm.
So what does that look like for you guys? Like, I can imagine it can take an emotional toll on you guys as well.
Yeah, I mean, we cry with our patients, we laugh with them, we bring them out. My dream job would be to be a cheerleader for our patients. But yeah, it can be emotional.
Do they ever just sit there and confide in you guys sometimes too?
Oh yes.
Yeah.
And sometimes their whole life story.
Yeah, I can imagine.
But a lot of times they need that. They need the fun banter back and forth, and they need to tell us about their life or what they're doing for the weekend. But it's almost like they are here for cancer, but it's the last thing we talk about. So
That's nice, though, because that's one thing that they need to get off their mind in that moment so they can get through this treatment and be successful and things like that. I think we had a podcast with she was a caregiver specialist, and she talked about scanxiety and some of those things also. But she was like, sending memes back and forth sometimes is like the easiest thing to do. And I think about joking about TikToks. I do that in my office every single day. And so I can imagine probably myself doing that, just trying to alleviate, because I want to use humor as a de-stressor.
Yeah.
And so that's nice to know that people can rely on that too. And it doesn't have to be such a heavy moment.
Yes.
Because I'm sure it can be intense at times.
Yeah. And it's hard too, because like the caregivers, or the family members, like cancer just entered your world and they don't know that they're doing this and taking the independence away from their loved one because they're like, what can I do for you? I want to do everything for you. Let me take your shoes off. Let me cook you this meal. So when they come to us, it's like we give them like almost tough love and like give them that independence back of like, you can walk in the room yourself. You can get on the table. I mean, obviously we're going to help them.
No,
but some of them, it's like, that's what they need. Yeah.
Because I feel like seeing some patients, they do want to be independent and they don't want people to rely on them. And they struggle because people are always so nice. Maybe you want somebody to be a little bit tough on you too at the same time. So that's refreshing to hear that other people think that too. Because it's always so sensitive. You never know how someone's going to take it. So.
I remember when I was a new therapist, I was like trying to put a patient's shoe on for them. And they're like, I can do it myself. And I'm like, oh, shoot, like I'm doing the same thing. Like, I'm so sorry. So then that's when I started to really realize, like, you got to read the patient and what they need, what they want. Some of them want the extra coddling. Yeah. And we'll do that. And some of them want that banter back and forth. And, if we can make them forget why they're there for 5 minutes, then we've done our job.
That helps. Yeah. So you've been doing this for 12 years total.
Yes.
And how long have you been the clinic manager? How's that gone?
It's newer. I got moved into a supervisor role, 3 years ago, 2 years ago.
Okay.
And so this has been maybe like 8 months that I've been since September the manager.
Okay.
But I still get out there and treat the patients.
Well, that's important.
Yeah.
That keeps you going every day.
Yes.
So when you were a brand new radiation therapist, how did that affect you? Because did you have a cancer story? Is that why you wanted, like, what made you want to do this as a profession?
I think because I started off on the diagnostic side of things. I did x-ray for 4 years and I always wanted more time with the patients. My coworkers would get annoyed because they're like, okay, we got to get the next x-ray. And I'm like, but wait, I want to know what their story is. So, we're not here by accident. Like, it's our calling. And so it's no surprise that, like, I've followed into this journey because, like, I love the patients and that part of it. I feel like cancer is everywhere and that like I have family members that have had cancer. And so I feel like it's always been kind of just their calling.
Yeah. And that's good to just hear, like, your therapist is going to care about you. Your radiation therapist is going to care about you too. They're doing it for a reason. It's not just a job at the end of the day. Yeah. It is because they truly care about these patients.
Yeah.
And what we want patients to know too is that all of these do connect, and everybody's story can be so different, but there's always some similarities in there.
Yes.
And so I'm sure you see that on a daily basis almost.
Yeah.
Everybody's diagnosis may be different and where they're being treated is a different area, but it's the same process and a concept.
Yeah. Yes.
So,
yeah, absolutely.
Is there anything else you'd like to add for these patients just to understand any more things that maybe they might be scared about but shouldn't be?
Ask the questions. Ask if you need to ask the question every day, do it, but just ask the questions. I hope that we were able to kind of debunk some of these, misconceptions. But it's really, really actually a boring side of your journey. Just think of it as social hour. You're coming to hang out.
So I feel like some people, like you said, the Star Wars effect, that all the lasers are going to be there. Is that a pretty common thing that people ask? I'm just curious.
Well, a lot of people, I think, are like, oh, am I going to glow after this? Or, some of them are being funny, but some of them are like, oh gosh, really, like
really
radiation.
About it, yeah.
So I think that my spiel over the 12 years that's become part of my thing of like, there's no crazy beams that are coming out. I mean, when you hear radiation, you're like, are we going to see it?
Yeah.
It's invisible. You can't see it. And, that's another thing too, is patients are concerned that when they walk out of our room, are they radioactive? And there's some procedures that they are. However, with us, we're external, and the radiation, once it hits where we're treating, it kind of dissolves. And so like it's safe for us to come in the room right after. It's safe for them to hug their family or hold their grandchild on their lap. So they're not glowing. They're not radioactive.
Because that is something that I would think too. So the Hope Cancer's building was NARTI at one point and was a radiation clinic. And there are radiation chambers in there that are very old. And the first thing that when I started working there, they talk about them. And my first thought was, are these still active? Because I don't know. I don't know enough about radiation or being radioactive. If somebody's asked, are you radioactive? What does that even really mean?
Radioactive, like there's some procedures that they're essentially emitting radiation. You know, some so
get onto somebody or transfer to somebody else. Is that?
Yeah. Like they're,
It's just projecting almost.
Someone next to them could essentially get some kind of dose of radiation if it's like an internal source.
Okay. And that's probably how medicine was done 20 years ago. But luckily now we have all this new technology and Highlands killing it over here with their clinics and everything like that, and all you guys, and appreciate just all the things you do for these patients.
Yes. And we appreciate you guys too. Takes a village.
It does. It sure does. Can you talk about how important imaging is when it comes to early detection and treatment?
Yes. Yeah. I mean, the sooner that a patient can get their diagnosis, obviously the better their outcome, less treatment courses they might have, need to have. If we catch it early enough, for example, like a breast cancer, if we catch it early enough, they might only need to have the biopsy or a lumpectomy, to remove that tumor. And then that might be it.
Instead of full double mastectomy like you see on some people.
Yeah. So, getting your annual exams done is so important. Yeah. I know I try not to be that person, but I'm like, it is really important.
Yeah. It is. And I feel like younger and younger people now are getting diagnosed. Yes. And it's almost not a matter of when. It's almost, or if, it's when.
Yeah.
And that is kind of scary to think about, and how you can prevent and do the best that you can. But doing these early scans, especially for young women and young men too, there's a rise in prostate cancer right now in younger men. And and testicular cancer also. And that's so scary to me to think about.
Yeah.
I mean, I'm 36 and so is my husband. And he's a farmer, and to get him to go anywhere that is medical based is not fun or easy. Yeah. Something's got to be essentially falling off at that point. But I'm trying to get him to kind of see the light. Like there's a reason that they do these things. So.
Yeah. Early detection is key, and imaging is a huge tool in that. I've even I'm like, can I get a colonoscopy sooner than what I'm supposed to? I'm like, because we're seeing 30-years with colon cancer.
And there was just
going on.
American Cancer Society even just had a recent statistic that it was a younger age that's the rise that's being.
Yeah.
But 45 is when they tell you to do it. So how do we cross that path?
Yeah.
So it is younger people that are getting checked, and it's not too late. So.
Yeah.
What are some practical tips for patients to feel prepared or more comfortable for that first visit, even after their planning day, so they know what kind of to expect the next time? Mm-hmm. But are there any more tips you would give to somebody if their planning day is coming up and they're just not aware of what to expect?
So we want to start creating, kind of some educational videos, and maybe start posting those for the community to see. But I'm sure, don't Google too much, but if you want to see what the machine looks like, look up linear accelerator. But at that consult, ask those questions there too. They play, they have the opportunity to play some videos for the patients to kind of see what to expect. Okay. Some patients don't want to see it right then, but we can send them home with the link so they can watch it at home to prepare and see what this next planing session is going to be, or what the treatment's going to be like. Mm-hmm. Call the clinic and see if you can talk to a therapist or something, a radiation therapist, to explain what to expect. After they do the planning session, we have radiation therapists that are actually coordinators. They call and schedule the patients for their treatments. Mm-hmm. So they get a lot of questions there. So ask the questions, what to expect. Can I eat before my treatment? Can I take my medications? There's a lot of questions that patients have, because in radiology, they might have these restrictions.
Yeah.
So
That's good to know too, because I would have thought the same thing. Like, you probably can't eat or drink or whatever, but maybe you can.
Yeah, you
depending
can.
on your treatment.
Most of the time, yeah. Just keep up with your normal lifestyle.
So there's no silly questions. Is
No.
the end.
No silly
just
questions.
Ask all the questions you
Ask
can
it every day if you need to.
and no one is if they're going to give you an answer. And it may have been a simple answer, but sometimes you just need to hear that answer.
Yes.
So,
yeah, absolutely.
well, is there anything else you want to add? We've got about a minute left.
I don't think so.
It's gone by so fast.
Yes,
It's been such a great conversation.
Yes,
and I've enjoyed learning more too, just because I had no idea on some of these things. So I really appreciate your time today and the clinics and all the things that you guys are doing for these patients. And if anybody at home has listened to this and they have questions, call us. Call Miss Julie. She'll take care of you. She'll get you radiation therapists to talk to and answer some questions or some concerns that you guys may have. So thank you again for being here. And thank you to our listeners. I hope you guys enjoyed today's episode. If you heard today's episode and you felt inspired or had questions, feel free to contact Julie, like I said, or visit hopecancerresources.org and we can connect you with anybody that we can help with.
Yeah, absolutely.
Thank you guys.
Thank you.
Thanks so much for listening to Hope Unscripted.
Join us next time as we share real stories, meaningful resources, and reminders that you're not alone.
Until then, keep choosing hope.